So if we look at the paradigm where it's all about vascular supply and septic load, what factors do we have to try and give us more information regarding septic load? Well, there's a number of diagnostic imaging which can be performed quite easily, and there are some more invasive tests, as you would expect. So plain radiography is excellent. And I have to say, even if you do an x-ray at the outset and you're not entirely sure, what's to stop you repeating the x-ray in a few weeks? And if clinically the wound's deteriorating, then it might allow you to correlate whether there is deterioration within the bone itself. So even if you take an x-ray baseline and it doesn't dramatically show anything, do leave it a few weeks, and the chronicity and infection, if it's causing bone destruction, should become evident with a change in bone density. The sensitivity and specificity of plain x-rays, they're not as high as you would like, but it's an easy test to do. It can be arranged. A lot of podiatrists and a lot of junior doctors have privileges to arrange x-rays, and I do feel that baseline x-ray in a wound in a diabetic or vasculopath is essential to have some form of basic radiological imaging. Here we can see an area in the lateral aspect of the foot where you can see just the metatarsal head is slightly eroded, and this patient had an ulcer on their lateral aspect. So again, correlate the x-ray with what you've got clinically. Here's a patient who has got an ulcer in their first toe, and you can see in the x-ray that the bone itself is grossly destroyed at this point. So that would be highly suggestive of osteomyelitis in this digit. Magnetic resonance imaging for me is probably gold standard to identify any evidence of osteomyelitis. However, it does produce good anatomical correlation, but it is limited somewhat with bone edema and other factors that may be non-infective that show up on MR imaging. The sensitivity is about 90% and specificity 80%, so it is really very useful. However, time constraints for getting the MRIs does preclude their routine use. Here we can see someone with a heel ulcer. To me, I look at this MRI, I know the patient's got a heel ulcer, and I can clearly see that there's a problem on this weighted scan with changes in the calcaneal area between the more superficial and deep bone, and to me this suggests some infective element within the calcaneal bone. This is unlikely to heal with chronic conservative management. However, if you then show me this MRI scan, as a vascular surgeon, I will struggle to delineate whether there's an infective cause here. So I do believe that the radiologist is absolutely vital to present appropriate images following MRI imaging, and also to provide their expert opinion, particularly for images such as this. Nuclear imaging is still performed on some units, but it is probably, I feel, going to be replaced by less invasive imaging modalities. Poor specificity of less than 50% really relates to the inability to distinguish infective osteomyelitis from other inflammatory or traumatic conditions, particularly sarconeuropathy. But sensitivity is still good. Here we can see an area that's highlighted in the foot, so clinical correlation is vital because you don't really know where this is unless you've got the patient right in front of you. Here we can see some more nuclear imaging with additional hotspots around the proximal foot in this patient. So when we look at other radiological investigative modalities, well, you've got SPECT scanning, which is single photon emission computerized tomography, which really combines a bone scan with a CT scan to give you more information. However, it's not really widely available, and its use in osteomyelitis is still being researched, particularly for sensitivity and specificity. White cell scans were performed nearly routinely 15 to 25 years ago. However, there have been a number of issues trying to get the radioactive tracer, and also it is quite time consuming allowing the white cells to be labelled, reinfused, and the uptake on the infective or problematic area. So it is time consuming, expensive, and perhaps when MR is contraindicated, and it's not really a part of my modern vascular practice at this stage. PET scanning, I do believe, is a very exciting modality. It is where radioactive fluorine is attached to a glucose molecule, and then this accumulates at sites of increased intracellular glucose metabolism, with sensitivity even reported up to 100% in some studies and sensitivity above 93%. Combining PET with computerized tomography does improve the anatomical detail, and I do believe this will be gold standard in the next 10 to 20 years if the radiological imaging can become easily available. When we look at hematological analyses, I think this is important not only to follow a patient up, but if you're thinking of any intervention. We like to complete a full blood picture to look for anemia of chronic disease for the hemoglobin. White cells is important as a marker of inflammation. You want to know is platelets, are they excessively high, excessively low, particularly if you're intervening on bleeding risk, and also chronic indices of mean and packed cell volumes. Serum creatinine and calculated estimated glomerular filtration rate is essential for any cross-sectional imaging with the use of a contrast agent and for any intervention with an angiogram, but don't forget we also need to know EGFRs for antibiotic treatment. Coagulation screens are useful, particularly if a patient's on continuous heparin before an intervention, or whether you need an INR international ratio if the patient's been on warfarin. CRP is useful to review trends of inflammation and infection and can be used to evaluate the progress, but in my feeling this is more if there's systemic upset rather than a localized food problem. It's also useful to, don't forget, risk factor analyses, look for fasting glucose and lipid profiles, as well as other modalities for atypicals including vascular, like thrombophilia and thyroid function tests.